Okay.
Okay, so again, we're going to talk about congenital syphilis and HSV and how OBGYNs can help your pediatric colleagues. This is really a subject that is near and dear to my heart because, like I said, just working as an inpatient pediatric infectious disease physician, it is something that I deal with on a daily basis, dealing with children who are born to moms who have syphilis and or during this pregnancy and also may have active lesions of HSV. So we're going to start with congenital syphilis first. And sometimes I don't love the word congenital syphilis because that is an assumption that every baby who is born to a mom who has syphilis during pregnancy is born with congenital syphilis, which is not the case. Really, we should be calling this infants who are born or who are exposed to syphilis. But you have to start talking about this particular subject by looking at the epidemiology of syphilis among women who are in birthing years. And overall, the United States, we have seen this surge in syphilis, both in primary and secondary stages, and also an unknown or late stage syphilis across the board, specifically really from 2015 on, but it's really exploded since 2020. And when you look at the cases reported among women, you will, and compare that with cases of congenital syphilis, you will see that they echo each other. They follow each other perfectly. And that makes sense, right? Because when a woman is pregnant and has syphilis, then that risk of congenital syphilis increases, obviously, in the infant. So you can see again that this has exploded from 2020 to 2024. But honestly, when you look at the increased cases of congenital syphilis from 2015 until now, so over a 10-year period, the number of syphilis cases has increased by over 700% in the United States. And what we see in South Carolina definitely echoes that as well. So this is data across the United States, and it's just specifically looking at congenital syphilis. And you can see the cases have again increased over the 5-year period. We are close to 100% increase. So that just kind of tells you where we are as far as having a handle on syphilis. Because right now, just in general, I think all of us have a ability to maybe do a little bit better. This is why we're here to learn and try to figure out how to do that. When you look at the county level data, you can see the red line or the red circle is approximately where South Carolina is. And the majority of counties in South Carolina are in that high incident burden area. And so that makes it obviously more difficult, to sometimes capture patients who may have syphilis, especially during pregnancy, but B, dealing with infants who are born to these moms. And what do we do for those infants? I will tell you that the Department of Public Health, South Carolina DPH, has some good information on their website. You can print these out to put up maybe in your offices or hand them out. It's just good information for mothers, expecting mothers, to know what the risks are for your baby who could be exposed to syphilis during pregnancy. In the state of South Carolina, you can see that cases of syphilis have increased in women 20 to 39, which is typically what we consider an birthing age period. That 69% of cases were between those ages there. And then the number of cases of congenital syphilis or cases of syphilis among newborns has also increased, and that's a 533% increase in cases since 2015. So what we're seeing in South Carolina is pretty much what we're seeing across the board in the United States. So we know that pregnant women with syphilis infections there's maternal risk factors for that can increase a woman's risk to obtaining or getting syphilis during pregnancy. And y'all probably know these way better than I do, but sex with multiple partners, late prenatal care, no prenatal care, IV drug use, incarceration, unstable housing. So you can identify or use those risk factors to help identify patients. But regardless, we need to be doing universal screening of all women who are pregnant. And so for pregnant women who have syphilis, obtaining information concerning ongoing risk behaviors is very important, because just because you're treated for syphilis does not mean that you can't get syphilis again. And you can reinfect or you can get reactivation of syphilis. And so it's important to follow those moms during their pregnancy just to make sure that doesn't happen. Obviously, reinfection, which can happen, especially if partners aren't treated. Sometimes it's very difficult to identify the partners to get them in for treatment. They might not want to get treatment. And that increases the mom's risk of getting infected again. That does have consequences for the infant on what we do for them once they are born. So if mom has primary or secondary syphilis, you can give 1 dose of IM benzathine penicillin just to kind of get this out of the way. We all know right now that benzathine penicillin is hard to find. I don't know across the state how y'all are doing and being able to obtain it, but of the people who absolutely have to have penicillin for treatment, it is pregnant women. And we will talk a little bit about that in the future. We do know that Pfizer did an involuntary or a voluntary, recall due to particulate matter that was in the benzathine penicillin, and that's why we're having the shortage. Hopefully, we will get out of it soon. Most institutions are only using benzathine penicillin for pregnant women, even before, obviously, the actual infant themselves, because we can always, even though it's not optimal, do 10 days of IV aqueous penicillin in the infant. Obviously, that causes some issues in that that the patient would stay in the hospital for 10 days. It separates mom from baby. You have maybe problems with latching on and breastfeeding and all of those kind of things, but it's better than nothing. So really, we should be only using benzathine penicillin now for pregnant women. So if you have primary or secondary syphilis, usually 1 dose of benzathine penicillin would be adequate, but you can repeat a second dose 1 week after the initial dose. If syphilis is diagnosed during the second half of pregnancy, then we should be doing an ultrasound for fetal evaluation of congenital syphilis if possible. It's very important to make sure, if we can, and I know a lot of times it's difficult to get these moms to come back in for their repeat doses, but when we are having to do 3 doses for latent syphilis, obviously they need to be approximately 1 week apart. If it is greater than 9 days between doses, then you have to restart the 3-dose series, or if there is a dose that is missed. And that's very important for the pediatrician who's looking at this information, because if mom is not treated appropriately during pregnancy, then that automatically puts the kid into getting a lumbar puncture and getting IV aqueous penicillin for 10 days in the hospital, no questions asked. So what happens to mom greatly affects what we do for the infant. Documentation, y'all, is key. This is the best way to help your pediatric colleagues. We spend hours going through charts, calling DPH, trying to find dates that moms were treated with benzathine penicillin. It probably is the most time-consuming thing that I do as a pediatric infectious disease physician. So if you could someplace it clearly in your note, write down dates of when the patient was treated with benzathine penicillin, that is half our battle, to try to figure out what we need to do with these infants. And so that would be my biggest suggestion for y'all to help us out, is making sure that that information is somewhere in the patient's notes that we can get. Now, not everybody uses Epic or, and that seems to be, at least for MUSC and the Prisma hospitals, and I'm pretty sure Lexington as well. I'm not sure about other places. I know McLeod systems use Epic as well, so you can do care everywhere, but there's some uh, individual practices that don't share notes. And so if in the admission note, if you could put that information in the admission H&P for the mom, again, that is so helpful for us as pediatricians. Titers, you need to at least wait for repeat titers at least 8 weeks since therapy, because you are not going to have a drop in your RPR before then. And so that's really important to know. Also, not every mom, actually most moms aren't going to have a 4-fold decrease in titers before delivery. And we know that, but it doesn't necessarily indicate treatment failure. That's really important to know. But of course, we do look at what those titers are, just because A, we have to compare them, the infants' titers to them, but B, it's also what tells us if mom is reinfected or if there's a failure in treatment, right? So we know that when you look at actual RPRs, those tests are done manually by an individual tech who's doing them. And so that's why you have to have a 4-fold titer increase, which is 2 dilutions, for it to be a positive test or considered reinfection, because every test is plus minus 1 dilution, just because there's human error in doing this test. Okay, so what do you do if a mom has a penicillin allergy? This is where you absolutely have to have desensitization and treatment with penicillin. A couple of different reasons. Number one, you can't use tetracyclines in second and third trimester. Number two, if mom happens to be treated with doxycycline, that is an automatic lumbar puncture, complete workup for congenital syphilis in the infant, and the infant is hospitalized for 10 days getting IV aqueous penicillin. And that's whether or not mom responded by titers to the doxycycline. We consider that not effective therapy because there's so many failures with doxycycline that it's an automatic treatment for the infant. We do know that syphilis and HIV go hand in hand. And so when you have syphilis infection, that can increase the risk to mom and the infant for HIV infection as well. And so every mom who is syphilis positive should also have an HIV test as well. So this is also the next thing that has changed over over time, that the CDC says that every woman needs to have a screening syphilis test in first trimester, and that if you live in an area where there are communities with high rates of syphilis or women who have been at risk for syphilis acquisition, that you need to repeat testing at 28 weeks, which is usually, they'll say beginning of the third trimester, and also at delivery. Okay, that delivery RPR is super important because there is time in between, obviously, the third trimester and delivery a lot of times. And so I need to know if that titer has gone up on mom to make sure that there wasn't reinfection during that time, because that does change what we do for the infant as well. ACOG did come out in 2024 with a practice advisory that also echoes what the CDC says, and they say across the board that all pregnant women should be screened for syphilis in the first prenatal care visit, followed by universal rescreening during the third trimester and again at birth. So this should be an automatic for every OB/GYN in your practice to go ahead and know that you need to be ordering these tests every time, in the third trimester again, and then at birth. And I think in Prisma, we are working on trying to change some of our admission order sets, hopefully to kind of reflect this, so it's automatically done when the mom comes in. So again, what can you do to help bridge the gap between OB/GYN providers and pediatric providers? Just knowing and documenting in your note mom's serological status for syphilis and history of prior treatment. That is so, so, so important. And just knowing and being proactive in getting these moms repeat tested in the third trimester and at time of delivery. This is just, I'm not going to go through this, but I want y'all to see what we look at every time an infant is born to a mom who has been syphilis positive during pregnancy. This is the algorithm that we go through. It is very complex, and there's a lot of things that we have to take into consideration. But here with maternal treatment, it all branches from how mom was treated. And you can see here when I was talking about that non-penicillin drug automatically puts you into a full evaluation and treatment. And so it's very important to have that information. This is just another closer, diagram that you can see. That's that middle part, just to show you what we look at. So what do we have to do as pediatricians to the infant for a full congenital syphilis workup? So obviously a physical exam, we're going to be doing either the RPR or the VDRL, depending on what was done on mom, on the baby. And then we do tap the patient. So we get CSF fluid and send that for indices and a VDRL. We're going to do long bone x-ray films. We're going to do a CBC, and then we're going to do other tests like neuroimaging, eye exam, hearing test, those kind of things. If we suspect that this is a high probability that the kid has congenital syphilis. Any baby who's abnormal with a abnormal physical exam is automatically going to get all of those extra testing. And then our treatment options depend upon what happened to mom, and also comparing baby's RPR or VDRL with mom's RPR or VDRL. And so it can go anywhere from no treatment whatsoever and just following the RPR titers, or we can do IM benzathine penicillin, or we can do IV aqueous penicillin for 10 days. So just some conclusions. Again, the highlights that I want y'all to remember is doing the best with the documentation that you can do, making sure that we are screening at first trimester or first time the mom comes in to see you, and then again at third trimester and time of delivery. And please, if you suspect congenital syphilis or if you have additional information, please just get in touch either with the pediatrician or Peds ID if you have any questions. All the pediatric infectious disease people in the state are super nice. You have great ones in MUSC and also in the upstate. And then I help take over and help with McLeod. So I can do a lot of the PD stuff and also the Midlands area.